I think we're going to do, we're going to do the questions again, or the, we'll do an interactive case. This is provided by Helen. So Helen, do you want to do the honors?
Sure. So this is a young woman, previously healthy. Good Lord.
Just push it back.
Young woman, previously healthy, Asian, but with a smoking history, with a cough that responded to antibiotics. I think it likes only one microphone. Let's try that. But then recurred 6 weeks later. Symptoms got worse. She had back pain, which was initially attributed to the cough, and imaging here shows an infiltrated mass, which you can see is PET positive, and the histology on the biopsy on the right.
Me.
So she had good performance status. The back pain was found to be due to bone metastasis in both T7 and T10. She had unremarkable labs. And what should we do?
So please vote. Okay.
All right, well done.
Smart group, 88%. We get a B+. You want to comment, Helen, and the other two?
Well, so I think everybody's paid attention to all the talks this morning that say we need biopsies. When we guess, we're often wrong. So this woman has some conflicting demographics. She's Asian, which gives her a high chance of an EGF receptor mutation, but she's also a smoker, which lowers that chance. And I think that's probably where the 8% with osimertinib, with or without bevacizumab, we're thinking.
Okay, let's keep going.
So the next thing is then, how do we biopsy?
So do we do left lower lobe specifically just for EGFR, ALK, and ROS1? Do we go after the bone met, T7, for the same? Do we do plasma testing by quote-unquote FDA-approved test? Plasma testing by another means, or none of the above? Helen, you want to comment on this
So
too?
this is very interesting and is mostly what I was trying to get to by this somewhat tricky question.
It's a very tricky question.
It is a very tricky question. The actual answer is none of the above, so I'll explain why. So if you do a CT-guided biopsy of the left lower lobe and you're just looking for those 3 genes, then you're missing a lot of information. If you do a CT-guided biopsy of the bone metastasis, you can't get accurate genetic testing because of the processing that's required for the bone met, even though it's a bit safer to biopsy a bone than to biopsy a lung. The only FDA-approved plasma test is only going to look for EGFR. Plasma testing by another test is actually a possible answer because, as Lud has shown you, and as we looked at from the very small amount of data that I showed you, the plasma testing, if positive, can be used for actionable mutation profiling. However, the real answer, in my view, is none of the above, and the none of the above is to do a tissue biopsy for next-gen analysis.
Comments, Chero or Luda?
Yeah, I completely agree, because you are missing, with the data that's coming out for RET inhibitors, the LOXA292 looked very promising at ASCO. I think we don't want to miss anything else we can target. There are a couple of rare mutations which we haven't discussed yet, such as NTRK mutations, which have excellent drugs in clinical trials and hopefully soon to be approved.
Shara, anything to add?
Yeah, I would agree. I think starting with plasma is certainly reasonable because the yield of catching something that's potentially actionable is quite good. It doesn't replace tissue biopsy, in my opinion, but I think starting with plasma is probably appropriate. And I would say that this patient is a smoker, so important to get PD-L1 testing to get a sense of, if she does not have a molecularly targeted or an oncogene-addicted tumor, where can we give her immunotherapy alone, or should we give her combination chemoimmunotherapy? Could she be a candidate for other clinical trials? So I think in addition to NGS, I will also put in a plug for PD-L1 testing.
So as Chair has pointed out, we will, in addition to tissue, frequently get plasma testing as well. We have a commercial alliance with Guardant, but there are so many other companies as well that are doing this. And as I think all of you have pointed out, I know, Helen, you pointed this out, I think all three of you had the pie charts that showed that plasma will pick up some mutations that are simply not seen in the tissue, maybe because of sampling or because of inadequacy, which is still a big issue. In our initial evaluation of tissue and plasma together, published last year by Jeff Thompson, Charu, and Erica Carpenter, who met yesterday, were integral to that effort. About half the patients did not have tissue. Either the tissue was inadequate, it was QNS, it was inaccessible, the patients refused biopsy. So it's a major complement. Of course, in initial diagnosis, you need tissue, for sure. And really, as Leslie Litsky pointed out yesterday, we look at PD-L1 in concert with everything else. I think the final point, particularly as RET is now turning into an upfront actionable marker, that pie is getting sliced and diced at increasingly tiny intervals. But each one of those intervals, each one of those slices has unique oncogenic drivers or driver that has unique therapy. And it's important not to miss that. The patient's progression-free and long-term survival really hinge on that.
And if I can build on that, so more practical considerations. When you're taking care of your patient, because PD-L1 testing is an immunohistochemical test, most likely in majority of this institution, it will come to you before you have the molecular testing. So if you have a patient with PD-L1 high tumor, as been shown by Dr. Aggarwal, that should not be an indication for you to give them PD-L1 inhibitors, because they could still have an EGFR mutation or ALK mutation. And the Lisberg paper is actually very sobering that there was no responses in the patients who were PD-L1 high who had an EGFR mutation. So I would wait.
It's hard. It's because you're tempted to start immediately.
Exactly.
You have that result.
And the patient wants you to, because they see the glossy ads for the immunotherapy, and so they know that they're
As
PD-L1
Beth
high,
pointed
and
out
that's
yesterday, direct-to-consumer marketing has a big influence.
But this also is where I think we really need to engage the other members of our team. So the pathologist down in his or her lab that doesn't have the patient right in front of them doesn't always have the same experience of urgency with getting the tissue processed and out. And the pathology systems are very carefully systematized so that everything is done right, but are not designed to do anything fast. And so getting your pathologists to process tissue and get it out quickly is really the key, in my view, to cutting down some of this turnaround time. We send ours out to a local lab that will do a turnaround of about 10 days.
Wow.
But
10 business days or 10 consecutive days?
About 10 consecutive days. But to do that, you've got to get the tissue to them quickly. So in our institution, if you biopsy on Wednesday, it's probably not going out until Monday or Tuesday. And so that's already built in a delay that's not great. And so you have to really micromanage that, especially since the electronic systems don't talk to each other from the clinical system to the path system.
So remember, if you've got a sick patient and you have a high index of suspicion, while you're doing the NGS, it's reasonable also to do spot mutation testing, I think, under those circumstances. Before we go into the interactive ARS questions, I want to ask each of you in sequence, before the advent of osimertinib, what your standard treatment was, and whether the lung 3 or 6 data influenced that decision. We'll start off with you, Luda.
My standard treatment was erlotinib, and basically mostly due to toxicity. I'm not, the exon 19 data in LUX-Lung 3 and LUX-Lung...
Can you clarify for the audience?
So the LUX-Lung 3 and the LUX-Lung 6 was a randomized clinical trials which compared afatinib to gefitinib,
to chemo.
To chemotherapy. And then they combined those analysis and showed that patients who have an EGFR deletion 19 mutations had a survival benefit with afatinib compared to chemotherapy. And patients who did not have, who had the L858R, there was improvement in progression-free survival, as did deletion 19s, but there was no improvement in overall survival. Personally, my personal feeling, I have not changed my practice. I'm not giving afatinib to my, was not, and am not giving afatinib to my deletion 19 patients. It's a single study, and we know that deletion 19 patients do better than L58Rs anyway, and I'm not sure that the single study will change my practice, and afatinib is much more
It was
toxic.
a retrospective analysis.
Yeah.
Helen, what was your practice before OC? Or I assume everybody's using OC now. Helen?
For the most part. I agree with Luda with a little bit of caveat in frail people, especially frail Asian people, for whom I actually sometimes will use gefitinib.
Gefitinib, okay. Chara?
So I use OC now.
OC, yeah, we all do.
So
Well,
the
not
question
all, but
is
most.
about what was I using before OC, and I have to say I agree with Luda. I think erlotinib is just so much better tolerated in my experience than afatinib that I was still preferentially using that pre-osimertinib.
So I'm the one outlier. I was using afatinib and exon 19, but not at the full dose. We'd start off at 20 and then build up if they could tolerate afatinib. My nurse practitioners basically rebelled. They said they would not start anybody at 40. The patient's quality of life and the staff's quality of life really depends on the toxicity profile of these agents, and 40 is really a tough dose. But it certainly had its role. And I guess the other thing I want to clarify is statistical significance versus clinical significance. The FLORA data look really positive, not just for PFS overall survival, but they weren't able to declare statistical significance. Luda, you were alluding to that.
I think the overall survival data is not mature yet,
Yeah.
so that's why. The hazard ratio of 0.64 is
pretty
actually
impressive.
pretty impressive. And when dacomitinib versus gefitinib overall survival benefit was revealed at ASCO, I believe, if you look back, the hazard ratio for that trial is 0.63.
Yeah,
So I think we just need time.
We're seeing a consistent
Yeah.
theme.
I
Of
think
course,
we'll need time.
it's second generation versus the third generation. So if we can go to the interactive questions. So, by way of our little discussion here, 46-year-old never smoker presents with headaches, brain MRI is alarming with multiple lesions and vasogenic edema, right upper lobe mass, mediastinal adenopathy, liver lesions. Right upper lobe is adenocarcinoma, exon 19 deletion. She gets whole brain radiation. Which of the following drugs is the best treatment option for the patient currently? So would you all agree, or at this point? So let me do a little thought experiment. If dacomitinib's toxicity profile wasn't so formidable, would you think that DACO might make inroads here, or no? Helen is shaking her head no, but not saying anything. Helen first.
Well, so I think the CNS activity is the real dividing line here. So I think that even with better toxicity, the answer is no.
Chara, you agree?
I completely agree. I think in the hypothetical scenario, if DACO was really well tolerated, I would still want to be able to offer high CNS activity. Again, we know that a significant number of patients never make it to second line. And I think just based on that alone, it's best to offer whatever we know at the time is the most active, well-tolerated drug.
You're not daunted by the fact that we really don't have a standard second-line treatment in this setting, whereas before 60% were getting T790 and sort of knew what to go to. Do we know the molecular profile of DACO resistance? Is it the same as erlotinib and gefitinib? Is it the same 50 or 60%, or is that not clear?
I haven't
don't think
seen
it's
it
clear
published.
yet.
I would expect it to be the same, but I haven't seen any data.
Okay.
Yeah.
And Luda, I imagine you agree.
I
with
agree.
OC
And
upfront.
the one of, toxicity being aside, my main rationale not to use dacomitinib first line is, assuming the resistant mechanism is going to be the same, that means that 40% of the patients will not have T790M. So for the 40% of your patients, your PFS is only 15 months, versus for osimertinib, the PFS is 19 months, the median, for 100% of the patients.
With
Plus,
a lot less toxicity.
Yeah, with
Yeah.
a lot less toxicity.
And with the brain activity. So thought experiment number 2, though, is should the patient have gotten whole brain radiation?
Exactly.
I was hoping one of you would bring that up.
And I think this patient had vasogenic edema, had headaches, and I think in patients who have multiple lesions, who are very symptomatic, I think it's a very fair question, should we even do this? But I do still refer patients for radiation that are very symptomatic or require steroids.
So Helen, would you just start steroids, hope that the symptoms get better, and then see how the OC would have
obviously
done?
we didn't see the brain MRI,
Right.
so we don't know how alarming this looks. But if the presenting neurologic symptom is just headache, I am entirely non-averse to starting steroids, and if the symptoms are getting better in a day, starting the
How
targeted
soon would you
therapy.
repeat the brain MRI?
Usually 3 or 4 weeks.
So just
and
to
3
make
or 4
sure
weeks,
things
you're
are
usually
going
actually
down.
seeing response. And if you see response and you have sluggish response in 1 or 2 places, our radiation oncologists are quite happy to do SRS to those lesions. So
Lydia, you practice on the West Coast, which is a hotbed of EGFR. What's your approach?
Same as Helen. So
Helen,
I
so-
would, again, those decisions in my institutions are done as a consensus decision between me and radiation oncologists. We can actually go on the phone and look at the MRIs together. I would start her on steroids. I would give her osimertinib. Even if the radiation oncologist already saw the patient before me, they still need time for simulation. I actually had patients where we were ready to radiate, and it took 2 weeks to do the simulation. And when the patient came in
brain mets with
for the
headaches,
brain
really?
mets, and then when
That
the
must be
patient
for
came,
SRS,
yes,
though.
Our
and
radiation
for SRS, and the
oncologists
patient
on
when
the
the
East
patient
Coast
came in
are a
for the
lot more
SRS,
aggressive.
the tumors were gone. So
Yeah.
like in 2
Yeah.
weeks, I've had patients responded as quickly as 2 weeks.
So they said, mistake, huh? I think it depends a lot on who sees the patient first. And a lot of radiation oncologists, I mean, if it's a nail and you got a hammer, you're going to bang it in. Multiple brain mets, vasogenic edema symptoms, the inclination is still to go ahead. There was this interesting retrospective study published in the JCO, I think you're probably all familiar with it, that looked at brain mets, looked at TKI alone, TKI plus SRS, or TKI plus whole brain, and granted, retrospective, not randomized. The groups that got both radiation and TKI actually had better survival.
This was
Thoughts
all
about that?
before the modern
So
era.
this is pre-OC.
So this is pre-OC, so not probably relevant to my decision-making now.
And it's also retrospective analysis, so we don't know anything why the patient did not get whole brain radiation. Maybe they weren't responding, they were poor performance status or something else. So I really, at this point, I think this study needs to be confirmed prospectively, and
That article is often trotted out by the radiation oncologist to justify going
So it
ahead
helps a
early.
lot if you have a multidisciplinary tumor board, because that gets everybody on the same page.
Sometimes.
Got it.
If we go to the next question. So a patient presents with metastatic non-small cell to liver and adrenals. Molecular testing again reveals exon 19. Which of the following strategies have been shown to improve, and this is why I was going through that discussion. Let's use the term statistically significantly improve both PFS and OS compared to either chemo alone or first-generation TKIs by either prospective or retrospective analysis. There's a lot of little caveats here. So it actually went down, okay. I think people are very impressed by, the OC data, of course, also have gone down. What's gone up is number 3. The study that seemed to have come out of left field, because I don't remember even knowing about that trial. So, Charu, what's your thoughts about that? Do you think we're ready for a study that would perhaps compare OC to OC-PEM carbo, maybe in sicker patients?
I think that's a question that's begging to be asked. I think gefitinib was a perfect TKI to pair with chemotherapy on that trial, because we know that.
Well, that was what was available at the time.
Also, I think in hindsight, sure, that was available, but it's one of the better agents that can be combined with chemotherapy with less toxicity. I think knowing what we know about osimertinib, it would perhaps marry well with chemotherapy, and I think it would be a very interesting study. I would definitely sign up patients
You would
for.
put patients on, Helen? Would you put patients
Yeah,
on
I
such a
absolutely
trial? Lita?
Yeah, I think 52 months is
All
pretty
patients
impressive.
or just those who are really sick? or it doesn't matter?
Probably put all patients.
All
in.
patients.
Yep.
Because
How long would you give the chemo?
4 cycles?
Continue the PEM as maintenance or stop?
Maybe, maybe not.
Maybe.
Probably-
have a,
probably
maybe have
maybe
a
not.
third arm with maintenance PEM. I think this is what we really need to explore. Is anybody aware of such a trial?
I'm not.
I guess we can originate it here. You know, in the old days when we were giving TKIs empirically, before we even knew about EGFR mutation, there was concerns about antagonism between the chemo and TKIs. But I guess these data would suggest that all bets are off if there's a driver mutation. So if we can go to the next question. Of all the actionable oncogenic drivers, which is the most common? Again, the key adjective here is actionable. Helen will comment after you vote. Okay, Helen. They've done pretty well.
Yeah, I don't think I need much commenting.
They did pretty well before,
They
but
did.
they've done even better. So KRAS is the most common, but as you alluded, it's not quite actionable. Any
Not
thoughts
quite
about
yet.
that?
Well,
That's not really what I asked you to cover, but
it is not what you asked me to cover. And, you know, I think we're getting there. I think that the key to looking at downstream mechanisms and inhibition of downstream pathways is where we're going to have success. The problem is that it's then not a 25% block. It's what the downstream issue is for each particular patient. So I don't think we're at a stage yet where we have sufficient understanding of the crosstalk between the pathways to make a plan. And I'm not aware of a study that has shed any significant light yet.
any other comments? Luda, Charo? So some questions are coming in. Any preference on TKI based on the different EGFR mutations, or I guess it doesn't matter in the OCR? Oh, we have one more question. Actually, we'll go to this question first and then go to the question here. It doesn't matter. OC is equally good for both, or?
So I'll take that. So for the sensitizing mutations, for the L858R and deletion 19, I think OC would be my first choice. However, for your atypical mutations, which we didn't cover today, so there is a mutation in exon 18, which we call an atypical mutation or non-classic mutations, which is usually L861Q, then there is like G718 something. Those mutations are generally resistant to first-generation EGFR TKIs, meaning erlotinib and gefitinib. Those mutations are generally sensitive to afatinib because there is a very nice preclinical data because of the way the afatinib binds to those mutations. It has been shown preclinically and confirmed clinically that afatinib would be the choice for that mutation. The recent presentation on osimertinib at World Lung, where osimertinib was tried for the atypical mutation, also showed some efficacy specifically for the L861Q, and again, all collaborated with the preclinical data. So I make decisions if I have a preclinical data and I have a clinical data follow with that. So osimertinib preclinically has been predicted to be highly sensitive for 861Q.
But we haven't seen quite as much data there as we have for afatinib.
We don't, but there is the ASCA, the World Lung presentation did show some patients, and the highest response rate was an 861Q mutation.
So you would use OC in the atypicals or afatinib?
OC. I will try
OC.
OC. Just
Helen, have you made the
toxicity-wise.
transition or no?
No, not yet.
So you're still using afatinib
Yes.
in that group?
Yeah, I haven't made the transition
So
either.
you're using afatinib, and I'm using afatinib, so 3 out of 4.
Luda's
And
probably
again,
right,
with the
though.
lower
We just
dose.
don't-
But I think we're all eagerly
for the
awaiting.
861, I'm definitely going to use OC. For the 861 mutation, I'm definitely going to use OC.
Okay,
The other ones,
okay.
And then for
Stay
exon
tuned,
20,
more data.
And then
Yeah,
for
for the exon
exon
20 we didn't
20,
talk
there
about.
is a clinical trial that's evaluating higher dose of osimertinib at 160. So again, there's a lot of variability in terms of the atypical mutations and what they may respond to.
Although when they compared 80 and 160, at least I guess in the second line setting, there didn't seem to be much difference in sensitivity. So please answer this question about sensitivity and specificity of liquid biopsies. 90-95% specific, sensitivity 65-70%. Second choice is a reversal of that, or they're both equally sensitive and specific at about 80%. Okay, Helen?
Well, It's difficult because these numbers are variable from assay to assay and report to report, but the general rule and the way to remember it is that if you find something in plasma, it's quite specific, so that 90 to 95% specificity
Maybe
is
higher than it
there.
really is, but it's in that ballpark.
Yeah, but the sensitivity is really the problem, and that's based on the amount of ctDNA compared to other cell-free DNA that's circulating, the amount that's shed based on how active the tumor is and where the metastatic sites are. And so if you've got somebody particularly who is progressing and you're looking at progression, because we follow these patients very closely now, you often see very small volume progression. And when you see very small volume progression, you may not have enough sensitivity from a plasma test. And that doesn't mean we shouldn't do it, because if you get something, then you can act upon it. But if you don't get something, you have to try and find another way to assay.
So the correct answer is number 1. Many of you still chose number 2, and I think this is an important teaching point. At least some improvements been seen. Obviously, we're hoping for a day when we get both of those up to 90, 95%. Shara?
So I think one of the things that we have shown recently in our publication with the use of plasma-based testing is that patients that tend to have M1A disease or intrathoracic disease alone tend to have much poorer yield in plasma. I think that's a limitation that we must acknowledge. Patients, and this has also been demonstrated in the melanoma literature, that patients with just cutaneous metastases or patients with brain-only disease, the plasma detection rate may be lower. So I think that's where most of the sensitivity is being driven from. But if there's somebody who has a lot of burden of disease, and we show this in our paper that was just published, that if there's liver mets and there is other visceral disease involved, that the sensitivity of catching a mutation in the plasma is pretty high.
Mm-hmm. So I think that's it for questions, or is there another? Okay. Questions come up, do all of the liquid biopsy tests use plasma? Or do some use serum? Does it matter? Comments?
So most of the ones that I'm aware of are plasma-based sequencing approaches.
I think that there are still some assays that people are doing in-house, but by and large, serum's gone away and plasma is preferred
But
choice.
the
And the
commercially
kits, I
available
think the kits
ones,
all use plasma.
Foundation, Garden, et cetera, are all using plasma. Another interesting question, what percentage of your EGFR positive patients, so mutant positive patients, make it to second line versus wild type patients? Is there a difference, or do you think these patients, because they've done so well with the first line TKI, that we usually whip them into shape and they're better capable of getting to second line? Lida?
So if you look at the FLORA data, actually in the supplemental figures of the NAGM paper.
Sometimes the most valuable charts are in the
it's
supplemental
figures,
tables.
exactly. 17% of the patients did not get osimertinib.
They died before they could get.
They don't say what happened, they just basically didn't get it. Either died or lost to
This is
follow-up
in
or
a
something.
control arm.
It's in a control arm. So
Okay.
when you got first generation EGFR TKI, and then 17% of the patients never got osimertinib, which to me it was higher than I was expecting. I was expecting 5%, 7%, but 17% is actually
Wow.
pretty high. And with the
Could have
chemotherapy,
been
we
a
know it's about
comorbidity,
30%.
could have been massive brain mets, things happen. Could have been small cell.
It could have been
Yeah.
PS got
Yeah.
worse.
What about OC? Your OC? I guess a lot of our OC patients have not had
Haven't
disease
progressed
progression
yet,
yet,
so-
and then another interesting question, what percentage of your EGFR positive patients, so mutant positive, are PD-L1 positive? And I think for the sake of argument, 50% or higher. Charo, what's your experience?
So from the FLORA data, they found about 28 to 30% were, or from the tested samples, were PD-L1 high. I would believe that that would be the prevalence. Certainly, I've had cases come back. If I were to guesstimate in our population at Penn, there would probably be about 30% or so also.
So you think it's pretty much close to the
Usual
the percentage?
prevalence.
Helen?
Yeah, I agree.
Luda?
I agree.
Really?
There is a paper. I don't.
My
can't cite
impression
it
is a
right now.
little bit lower, but not much lower, like 20, 25%. But needless to say, there are a lot of patients out there have not just EGFR, but oncogenic drivers plus high PD-L1, and I think as Helen's pointed out in her last slide, the oncogenic driver governs at least initial treatment. Now, you all talked about the relative inactivity of IOs of immunotherapy in this group, but that's single-agent IOs. So the combination with chemo after in the development of TKI resistance, I think all bets are off. Would you
Yes.
agree with that?
Yeah, I think Empower
And the
150
Empower
is
150.
actually
150
very clear that
shows
we need
that.
to
Yep.
investigate that region.
And I think our final question before we go to our break is actually breaking early. With first-generation TKI, we used to hear about dosing to toxicity. I guess an era when some of these agents were a little bit less toxic, although OC is the least toxic. In other words, adding food to increase absorption. Does anybody ever do that to OC? Does it matter? We pretty much stick with the 80 milligram dose.
I've been
Tara?
sticking with the 80 milligram dose, actually. Have had very few patients requiring a dose reduction. I think I saw one of yours, Corey, who was dose reduced, but really, I mean,
I've had, that's the one patient I've had that required. She's an outlier. She had more toxicity on OC than she had on her lot. And, for the most part, these patients come in and say, "Where is this? Why have you been keeping this drug from me?" Because the contrast between the two is so striking. Helen?
Yeah, I agree. I think that the dose to rash plan or dose to toxicity plan was really before we knew what we know now about the mutation status and how to look at these patients. So if you're starting with fatinib, there's enough toxicity to begin with, and I agree that the OC generally doesn't need to be escalated.
Mm-hmm.
So the only, I don't empirically dose reduce. I would consider 160 milligrams for patients with leptomeningeal carcinomatosis based on Bloom data. The Bloom study took the patients with leptomeningeal carcinomatosis as well as CNS metastasis and gave them all 160 milligrams of osimertinib. In the Bloom study, the data that has been reported to this point, we do not have any data on 80 milligrams, so we don't know if 80 milligrams is going to be as effective as 160. The decision to go with 160 was just a scientific decision by the company. If we give 160 and doesn't work, it doesn't work. Right. But if we give 80 and doesn't work, then we'll have to see if 160 is going to work. So I have been able to get osimertinib approved by highly prevalent HMOs in West Coast, showing leptomeningeal carcinomatosis 160.
Yeah, I've been able to do the same on the East Coast with our multiple insurance companies.